Hematonics, RA, sounds like a very big, complicated word, no? But really, it's for something so fundamental, the building blocks of our blood. And if you're going to build blood, you need two absolutely essential materials, iron and vitamin B12. So in this class, we're going to break down exactly how we use them as medicines. Cello, let's get started.
Okay, so here's the plan for today. We'll start with the first-line treatment, that's oral iron, and we'll see what happens when that's not enough. Then we'll switch gears a bit, move to a different piece of the puzzle, vitamin B12, and finally, we'll wrap up with a couple of key clinical questions, the kind that you will definitely face in your exams and in your practice. Right. So imagine a patient comes to you with iron deficiency anemia. What's your first thought? Your first prescription? It's going to be oral iron. It's the standard starting point, and for very good reason. But, and this is a big but, there is a catch you absolutely must know about. Now listen carefully. This is the single most important concept in oral iron therapy. I want you all to remember this. You'll see dozens of formulations in the market: ferrous sulfate, ferrous fumarate, ferrous succinate, all these fancy names. But here's the secret: the salt doesn't matter. What matters is the payload it's carrying, the amount of pure elemental iron. That is the actual active drug. And look at this table. The difference is just huge. A 100 milligram tablet of ferrous succinate gives you 35 milligrams of elemental iron. Not bad. But the same 100 milligram tablet of iron calcium complex, it gives you only 5 milligrams. See? So this is clinical detective work 101. If your patient isn't getting better, the first question isn't, what's the tablet dose? No. The question is, what's the elemental iron dose?
So why do so many patients just stop taking their iron tablets? I'm sure you've heard this. It's because that same elemental iron that builds blood can also, well, it can wreak havoc on the gut. We're talking a metallic taste in the mouth, nausea, and very often severe constipation. This, my friends, is the #1 reason for noncompliance. And that's why counseling your patient is so critical.
Okay, so what happens when a patient just can't tolerate oral iron, or it's simply not working? We have to escalate our treatment, right? This means we have to bypass the gut completely with parenteral iron. In other words, injections. So this brings up a very crucial clinical question. When do we make that call? What are the exact situations, the indications where you decide, okay, tablets are not enough, I must give an injection? Let's break it down. So there are 5 key scenarios you need to remember where you'll reach for IV iron. Number 1, severe intolerance to the oral pills. The patient just can't take them. 2, malabsorption, like an inflammatory bowel disease where the gut can't absorb the iron anyway. 3, simple noncompliance, they're not taking the tablets. 4, severe deficiency, maybe from chronic bleeding, where you need to fill up the tank fast. And number 5, a very important one, patients with chronic kidney disease who are on erythropoietin. Their demand for iron just skyrockets, way beyond what oral therapy can ever supply. Now listen, not all injections are created equal. Back in the day, we only had iron dextrin. And it worked, but it carried a significant risk of severe allergic, even anaphylactic reactions. Plus, the infusions were painfully slow. Today, thankfully, we have much better options like ferric carboxymaltose and iron isomaltoside. They are so much safer, and here's the best part. You can give the entire required dose in a single, short infusion of just 15 to 30 minutes. This is a complete game changer, both for patient safety and convenience. Okay, so we've covered the building material for hemoglobin. That's iron. But what if the problem isn't the material, but the factory itself? What if the bone marrow just can't produce mature red blood cells? This brings us to a whole different class of hematinics, what we call the maturation factors. And the key pathology here is something called megaloblastic anemia. Now, this is what happens when you're deficient in either vitamin B12 or folic acid. The fundamental problem, the basic defect, is in DNA synthesis. The bone marrow was trying to make red blood cells, but it can't complete the process properly. So what you get are these large, dysfunctional, immature cells called megaloblasts. So let's focus now on vitamin B12. There's a bit of history here. Decades ago, a doctor named Castle figured out that to cure a deadly condition called pernicious anemia, you needed 2 things: an extrinsic factor from food and an intrinsic factor from the stomach. We now know that that extrinsic factor he was talking about is vitamin B12. And what about that intrinsic factor? Well, this is it. It's a special glycoprotein made by the parietal cells of your stomach. I want you to think of it like a key. Vitamin B12 is the treasure, right? But you cannot unlock its absorption from the gut without this key. This is exactly why any disease affecting the stomach or any stomach surgery can lead to a severe B12 deficiency.
So, what is actually happening at the molecular level when B12 goes missing? It creates a critical traffic jam in your metabolic highway. You see, a crucial reaction that needs B12 as a cofactor gets completely blocked. And because of this blockage, another vital vitamin, folate, gets trapped in a totally useless form. This is the famous methylfolate trap we talk about.
And with folate trapped, you cannot produce something called thymidylate, which is a key building block for DNA. So no DNA, no cell division. That is the molecular root of megaloblastic anemia. You see? It all links back to B12.
So the consequences are twofold. Hematologically, you see the classic signs: the megaloblastic anemia, the hypersegmented neutrophils on the smear. But what is truly dangerous and specific to B12 deficiency are the neurological symptoms. This can be anything from numbness and tingling in the hands and feet to serious balance and memory problems. And this is critical. Listen, if you don't treat this nerve damage can become permanent, irreversible. All right, Chalo, let's lock in the two most important clinical points with a quick quiz. These are concepts you absolutely, positively need to have down cold. Ready? Okay, first question. True or false, all parenteral iron formulations, any of them, can be given as a single, rapid, total dose infusion. Think about what we just discussed, the old versus the new formulations. The answer is, of course, false. That rapid, total dose infusion is a massive advantage, yes, but it's exclusive to the newer preparations like ferric carboxymaltose. You absolutely cannot do this with the older iron dextrin. Okay, one more. Pay close attention to this one. Now, this next one is all about patient safety, so listen carefully. Your patient has megablastic anemia. They also have neurological symptoms, tingling, numbness. Why is it a huge mistake to only give them folic acid? And this is the critical take-home message for today. If you give only folic acid, you might see the blood picture improve a little bit, yes, but you are masking the underlying B12 deficiency. You're allowing the devastating neurological damage to continue and to become permanent. This is one of the biggest never-evers in hematology. Always rule out or treat B12 deficiency first. So let's end with this thought. You see, treating anemia isn't just about prescribing a pill to make a number on a lab report go up. It's clinical detective work. It's about understanding the specific cause in your specific patient so you can choose the right key for the right lock. That is the art and science of medicine. We'll pick this up and cover the other key maturation factor, folic acid, in part 2.